Welcome, everyone, and thank you for joining us today for the latest session in the Donald Maloney, MD, Dialysis Leadership Medical Director webinar series. I'm Kelly Brooks, coordinator for the Forum of ESRD Networks, and I have a few housekeeping items to go over before we begin. First, please remain muted to minimize background noise and interruptions. You will have the opportunity to submit questions using the chat feature. You may submit questions at any time during the presentation, and we will answer questions at the end of the webinar. Today's presentation is being recorded and will be posted to the forum website for future reference. A survey link to an evaluation form will be included in the chat and in a follow-up email you will receive after the webinar. We would very much appreciate your feedback. So let's get started. I'd like to introduce Dr. Daniel Landry, Forum President, who has some introductory remarks. Dr. Landry, are you here with us yet?
I'm here, Kelly. Thanks so much.
Great.
All right. Well, welcome, everybody. Hopefully, many of you here might be returning from prior talks that we've given so far. And for anyone who's new to us here today, welcome. As Kelly mentioned, this series of ours we put together over the last couple of months and we'll be concluding in another month and a half or so is something that came from a lot of work over many years and a desire to really just share the education that we've put together and the experience that we have with other people in the dialysis community. And I think this is yet again just another great opportunity today. And I certainly want to thank Don Maloney for everything he's done for the Forum of ESRD Networks. And we'll go to the next slide, please, Kelly. And as you can see, the different talks that we've given so far, they are all available online. You can go to our website to access those talks. They're YouTube recorded now. And I hope people really enjoy them. And we also very, very much appreciate your feedback. We'll take any constructive criticism you have to offer. Our goal here is to provide a free but informative experience for people so that they can come away having learned some things that, quite frankly, we recognize are not commonly incorporated into a lot of nephrology and kidney training. So we're hoping this is something that really adds to the education of people out there, not just nephrology fellows, but in early career nephrologists, but for all people who work in the kidney community. Next slide, please. And so today, it's my great honor to introduce someone I can proudly call a very good friend and wonderful colleague. Ramin Sam is a clinical professor of medicine at Zuckerberg San Francisco General Hospital, the University of California. He's the medical director of dialysis unit as well, and also serves on the editorial board for the American Journal of Nephrology. In his spare time, he's volunteered for the National Forum of ESRD Networks as the vice chair for our Medical Advisory Council and will soon be the chair of the council come this summer. He also represents ESRD Network 17. And most importantly, Ramin is someone who comes from a great deal of experience, particularly of many different areas, but one of which that I think you'll understand and appreciate today from the quality assurance and performance improvement perspective. He has a great mind for this, and it's an area that we all recognize that is an opportunity that we can apply to certainly in our dialysis clinics, but also in all aspects of healthcare work. So with that, I would like to have Dr. Ramin take the stage, and we thank you all for being here today.
Thanks very much, Dan, for the very kind introduction, and I'm gonna try to share my slides. Good afternoon, everyone, and thanks for joining. Okay, so the topic today is leveraging QAPI processes to improve patient care. And so the question is, why do we do quality assurance and why do we try to improve our I'm sorry, before I start, I just want to make sure everybody can see my slides. Is that
Yes, we can. Thank you.
okay? Great. So yeah, so why do we do quality assurance and why do we try to improve? And all of these are reasons we do that. Because CMS wants us to do quality assurance because the networks try to make sure we are doing them and doing them correctly. And with the QIP process and everything, there is some degree of financial impact as far as doing things the correct way, as you learned in Dr. Howard's lecture. But the most important reason why we do quality improvement is because it's the right thing to do, because we do want to provide the right care for every patient every time. I want to do that what is right for patients and what benefits them the most. So this is a picture from more than 100 years ago. This was a picture of Dr. George Haas, who did the first hemodialysis on a human in October of 1924. And since that time, we have come a long way. We have not only improved the dialysis process technically, but we have also have improved our quality improvement, our research criteria for including patients, and the way we do ethics in general. So this is also from a while ago, from 1962, and it is an article in Life magazine, which shows when dialysis first came about, and there were very few centers that did dialysis, and it was difficult for a patient to become a dialysis patient, and then they had to have a committee where they decide who to put on dialysis and who not to put on dialysis. And this was the beginning of the modern medical ethics. And so dialysis in a way is one of the initiating events that we started medical ethics, and it's good that we continue on that route for now. So the goals of the QAIP PI process is measuring outcomes, collecting data, and then to analyze those outcomes and see which outcomes we are doing well on and which outcomes we do not achieve the goal that we have set for ourselves, and then come up with a plan to improve the outcomes that are not as good, and then continue to monitor the outcomes every month frequently and make adjustments to keep improving, achieving the goal that we have set out for ourselves. So the important thing to keep in mind is we do not want to make that goal something that is not reasonably achievable. We want to make sure that the goal is within possibility, so we can achieve it in a period of time that we have set out for ourselves to do it. So today's talk, agenda for today's talk is, first I'm going to talk a little bit about who is in the QAI team, who are the team members. Then I'm going to go over what measures and what outcomes are to be discussed during the meeting. Then I'm going to go over some steps to collect data, analyze data, come up with a plan, and improve outcome, which is the goal of the QAI project. And then I'm going to point out some tools and resources that are available from different organizations about ways to improve, to do QAI and make the best out of it. And next, I will talk about a little bit about the regulatory survey, what they look for, what they do, and how can centers improve in that process. So the first topic is, who are going to be the QAI team members per CMS conditions of coverage. So there are certain team members that are mandatory to be there for every QAI meetings. Medical director is the leader of the QAI process, and the core leader and core importance is the nurse manager or the facility administrator. Who is always present at these meetings. And then there has to be a dietitian present, social worker has to be present. And if the unit has a facility administrator, then there has to be a charge nurse who's going to be representing the nursing area of the dialysis unit. And then finally, the mandatory presence has to be a biomed that will go over the border outcomes, and there are also people who are encouraged to be present. First is director of operation of equivalent. If the unit has one, other nurses may be present. There's a lot of new initiatives to include patient care technicians, and they bring a lot of important things to the table. They can oftentimes they're the ones that are most aware of the patient's accesses, the graphs, fistulas. They can really contribute to the meetings, and it is helpful to have them be present during the QAI meeting if possible. And finally, patients should be encouraged to attend in the right setting. And I'm going to talk a little bit about uh, patients being present in the QAI process. There's pros and cons to having patients in the QAI process, and I'm going to go over them. So the pros of having the patient present is, it gives you a patient's perspective, and that's not always visible to the other team members. When patients are present, they can clearly state that, and it shows that patients have a seat at the table, and it's going to be helpful as far as patient wishes, and and also it shows that patients and families are prioritized during the QAI process, and patients' concerns are brought to the attention where they may otherwise not be. So this is the most important reason why to have patients in the QAI participate in the QAI process because their concerns that may not clearly be visible to everybody are brought up if the patient is actually present at the meeting. But there are also cons of having patients at the meeting. One issue is HIPAA issues. So, if there are patients, particular patients are not supposed to be discussed in the QI process, but sometimes, there has to be some discussion of patients. For example, if you look at vascular access and how many patients have catheters, sometimes it's necessary to see who are the patient outliers, and things like that can violate HIPAA issues. And if patients are included in the QAI process, there has to be a system where no patient-specific material is discussed while the patient is present, and all those things should be present when that representative patient is not actually present. And also, all dialysis units have things that are really good at, and also have things that are not so good at. And if patients are observed that this dialysis unit is not so good as some other dialysis unit in a certain aspect of the QAI process, then it may cause unnecessary anxiety, and even it may lead patients to wanting to transfer to other units, which is not always the best thing for them. The other units may be farther away from them. There may be other reasons why it is not most beneficial for the patient to do that. So it's going to be tricky to include patients in that QAI process, but I think the networks should provide some technical assistance to projects, participating facilities on cooperating patients, family members, caregivers in the QAPI program and governing body of the facility. There's what needs to be discussed during the QAI process. So this is the answer to this, and that the simple answer to this is basically everything. So if the state is surveying the dialysis unit and is asking to talk to the medical director of the dialysis unit, and the question that they often have is, how do you make sure a certain outcome is monitored and improvements are made in that outcome? If that question is posed to the medical director, then the answer to that question should be through the QAI process. So what that means is, anything that involves the dialysis unit, and the medical director is, is the leader of the QAI process, but also they are responsible for anything that happens in the dialysis unit, and they're the one who ultimately bear the ultimate responsibility. And for them to be able to do that through the QAI process, anything that affects patient care should be discussed in the QAI process. So first, there are quality measures that need to be discussed. For example, adequacy of dialysis, how many patients are getting adequate dialysis, what percent of patients are not, the ones that are not getting adequate dialysis, how can we improve them and get them out of the outlier list. Nutritional status like albumin and PCR and other things may be discussed in the QAI process. Obviously, bone mineral metabolism, calcium, phosphorus, and PTH trends for the whole dialysis unit, and data should be presented at the QAI process. Anemia measures are important measures that need to be presented. And vascular access, what percentage of patients have catheters versus grafts versus fistulas need to be monitored. Vaccination rates, the most important vaccinations that need to be discussed at the QI process include flu vaccine, hepatitis B, and pneumonia vaccine. But in addition to that, to those other vaccinations can also be monitored. And how many patients have died during the month that the QAI is being discussed should be monitored. Why did they die? Was it dialysis related? What was the potassium the last time they were in the dialysis? And all of those are important measures to monitor. Mistreatments, obviously mistreatments lead to a lot of bad outcomes. They lead to hospitalizations, rehospitalizations. They lead to worsening of all of the measures that we have talked about. They have listed on top here. Making sure that as few mistreatments as possible are happening in the dialysis unit is very important. And if the unit has home patients, then peritonitis rates have to be discussed. Foot checks in diabetic patients, how many patients with diabetes are actually getting foot checks, as that's the major problem with patients with diabetes. And medications reviews. Are the medications are being reviewed every month? I mean, I think this is a little deceiving sometimes because a lot of dialysis units it's very easy to check a box and say the medications were reviewed, and that's probably all then usually that states is requiring as far as medication reviews. But it's very important to actually have patients as much as possible bring in their medications and have them actually go over one by one, and also to let the providers know of all these medications that were reviewed and if there's any changes that need to be made. That's probably one of the most important aspects of patient care in the dialysis units. And it is probably should be more than just checking the box, but unfortunately I found that many dialysis unit it just becomes a check the box issue. And there should be some degree of measurement of blood pressure management, fluid management, dry weight management with that, when we do the QAI process. Then the next measures that are discussed in QAI projects are patients events, adverse events, and we'll have a subsequent slide on this, detailing all the things that need to be monitored in the month that the QAI process is discussing. That will include adverse events and patient grievances. And any simple grievance should be included. It's patient stating, for example, that it's too hot, it's too cold, or anything that comes up. The unit should try to make the best effort to bring up everything that may include the patient grievance. Infection control audits, making sure that all the infection control practices are followed. I think Dr. Bradley gave us a great talk on that topic, and during QAI we got to make sure that those are everybody's following those measures. Hospitalizations, how many patients during that month were admitted to the hospital? Why were they in the hospital? How many of them were dialysis related? Hospital readmissions are very important, especially if they're dialysis related again. How many patients have been referred for transplant? How many patients are waitlisted? Because ultimately the best option for dialysis patients, if they're candidates for it, is to get a kidney transplant. It has much better both mortality and morbidity compared to continuing on dialysis. Hep B surveillance is important, making sure all patients who are Hep B surface antibody negative are getting a surface antigen checked every month, and patients who are surface antibody positive are getting a surface antigen and surface antibody checked biannually, or at least annually. And then there are measures about the physical plant and water system that needs to be discussed in the QAI process. Chlorine testing is very important. We want to make sure that the chlorine tests are done every 4 hours as indicated. And if that's how the unit is doing those testings. And we want to make sure water cultures are done monthly, endotoxin levels are checked. We got to know how many dialysis machines broke down during the month and what was wrong with them, and were they able to fix them. We got to know, for example, how many hours the dialysis machines have on them. Is it time to order new machines? Are there are there machines that are breaking down very often and need to be replaced? Emergency preparedness is also something that should be discussed during QAR to make sure people are following that. And life safety events, for example, are all the alarms calibrated, and fire alarms are online and working. All of those events also should be monitored. And then the next topic that should be discussed in QAI is staffing, education, and other things like patient education. Are we giving patients education about their diets, high phosphorus diet, low salt diet, and other things, emergency cases where the patients know how to take themselves off our dialysis and stop dialysis in case of major emergency. The modality education is very important. The patients are aware of home dialysis, peritoneal dialysis, especially since we are trying to advocate for more home dialysis in the dialysis unit. So staff education and credentialing should also be, we should make sure that all of those are up to date and up to standard. Staffing of the dialysis unit should be discussed. How many job openings are there? Are we looking for more nurses, PCTs, or dietitians, or whatever the case may be? Are the plan of cares being completed on time? Were there any myths? What was the reason they were missed? Often I find that most often the reason that they're missed is patients have been in the hospital for a good portion of the month, and the POC was not being able to be done because of that. And timely completion of medical records, making sure that medical records, the orders are signed within 30 days or whatever the requirements are, and also the Q and KDQL completion rates. Regulatory measures that needs to be discussed during the QAI process, the results of state surveys, if there are any, reports from ESRD networks, reports from other regulatory inspection agencies, and yeah. And then other measures that may be useful to discuss during QAI measure. I usually start at the QAI meetings myself with, getting to know how many patients are in the dialysis unit, how many were there the month before, how many admissions were there, how many discharges were there, and what was the reason for the discharges, were there transfers, were there deaths, transplants. And it also is sometimes useful to know how many treatments were done, how many dialysis treatments were done during the month, how many patients missed dialysis treatments, and I think we talked about some of those things. So those are the basic things that need to be discussed during the QAI process. Now I'm going to go over some of the things specifically. So adverse events. So what constitutes adverse events that need to be discussed during QAI? And this could be pretty long, and this could include things like infiltrations. The fistula grafts, how many of them had infiltrations, especially if the infiltration resulted in discontinuation of the therapy or having to had to resort to other temporary accesses, the catheters. If the bleeding occurs greater than 100 mL, that should probably be brought up during QAI meeting. Medications errors, for example, not giving the ESA, giving the wrong dose of the medication, things like that should be brought up as adverse events. If the patient falls during dialysis or in the dialysis unit, that should be discussed. If one uses F160 rather than F180 dialyzer, then that needs to be discussed. Any deaths that happened in the dialysis unit, obviously is considered an adverse event. Cardiac arrest during dialysis. If the dialysis unit is performing blood transfusions, then if there's a transfusion reaction, that needs to be brought up. If there was a chlorine breakthrough, machine malfunction leading to dialysis interruption, patient transfer from dialysis to the hospital, hypotension leading to loss of consciousness, pyrogenic reactions. If there are any needle stick injuries to staff, that needs to be brought up because that represents a major event. Any blood or body fluid exposures should also be discussed. And also abusive behaviors, and both in part of the patient or staff, are some things that need to be brought up during the QAI process. So this is the first page of the Medicare conditions for coverage. As you can see, the last time this was updated was April of 2008. So it's almost 20 years that this hasn't been updated, and it's probably time that this needs to be updated. This is basically the guide for dialysis units of how to do dialysis, how to be compliant CMS wise with performing dialysis. And if you look at it in more detail, if you actually dive into the actual conditions of coverage, this is an example of what you find. And a lot of times, I find it pretty hard to follow. And a lot of it is basically there's a period of time where the CMS puts out the conditions of coverage, and then it gives agencies or groups to comment on that, or any individual people to comment on the conditions of coverage, and they would then respond to these conditions of coverage. And a lot of these points in the conditions of coverage are basically the comments that were made and the responses to those comments. And I think we can read the response here as an example. The commentators are correct. The bullets above do not accurately reflect the guidelines. However, the language will not appear in this final rule since the issue is covered by this section 7.21.1. So it's kind of hard to follow. You have to go to other sections to see exactly what they're talking about. So they're not, there is room for improvement about the wording of that. So the goal of the QAI process is to improve care. And how do we do that? So what we need to do is, where are we at currently? Is there a problem, and what is the problem? What is the data show? And then the next question would be, where do we want to go from here? How do we want to improve? Where do we want to end up? What is our goal? And then, the question is how to get there, how to achieve the new goal. So this is an example of how QAI process can be used to improve patient care. For example, let's say the catheter rate raise in a dialysis unit is 35%. That's pretty high. Ideally, we should be less than 15%, although I would say that's sometimes very hard to achieve. So the plan, a realistic plan is made to decrease the catheter rate to 25% in 1 year. So the monthly meetings are arranged between the medical director and nurse manager to discuss every patient with the catheter, and we can remove the catheter and give them a permanent access. One thing that is done is emails sent to vascular surgeon about one specific patient every month for a fistula to be placed on an urgent basis. So this way we can get slowly cut into the number of patients who have catheters. And then further review is done. It's always the process where we analyze data and more data and dig into more data. And we show that 10% of patients have long-term catheters due to comorbidities and refusals. Another 10% have maturing fistulas grafts, and 10% are awaiting permanent access placement. So after 1 year, despite all of the efforts, the catheter rate declines, but we still are not able to achieve the goal. So this time, a nurse practitioner who is in charge of many patients in the dialysis unit is added to the vascular committee to try to improve, to get more patients permanent access. A whiteboard, which has a cover on front of it, is placed in the dialysis unit, which lists all patients with their appointments during the vascular appointments during the week. So this way, all the nurses and all the care team can look at that board and see which patients have appointments on that day, and when they show up for dialysis, they get frequent reminders of their appointments to make sure patients are not missing their vascular appointments. And for patients who continuously miss their appointments for vascular access, an attempt is made that anytime they get admitted to the hospital for any reason, we try to put that permanent access while they're actually inpatient. Despite all this efforts, the catheter rate declines but still remains above goal. I'm sorry. So the above technique results in placement of 2 more fistulas in 1 year. Then the issue continues, and root cause analysis is done, and it shows that the main block to getting more fistulas is because there's only one ultrasonographer doing the vein mapping, and that's really increases the time from referral to placement of fistula to around 3 months, which is a long time, and we're trying to cut down on that. So we asked the hospital to hire additional ultrasonographer. And we do have, and the unit has multiple meetings with the vascular surgery service and hospital leadership in the next few months to try to improve the catheter placement. After 6 months, no improvement. There is no movement in hiring another ultrasonographer. Catheter rate remains high. A decision is made to refer patient to outside surgeons. So, you can, as you can see, this is a continuous process where, you do one thing, you evaluate the results. If you don't find, you achieve the goal that you're looking for, you try something different. And you continue to add to it. So you can put it as 4 steps. One is plan, designate personnel and resources for each intervention, who's going to be in charge of improving this outcome, how are we going to measure it, should we target a specific group of patients rather than a subgroup rather than the entire dialysis patients, determine a timeline. When do we want to reach a certain goal, but what time? And then number 2 is do. So you implement the intervention that you have planned out to try to get the outcome that you desire. Then the 3rd step is study. So you collect data again, and you analyze the data, you study the results, and you document the results and see if you have achieved your goal. And if you have not achieved the goal, then you act and try to come up with a different plan to try to achieve that goal. So there are some resources that are available to improve the QAI process and improve patient care. There's this CMS obviously has the conditions of coverage, and they also provide other documents that may be of help. The Veterans Administration has patient safety resources. Agency for Healthcare Research and Quality has patient safety flyers and other information that may be useful. The CDC is very important in infection control and vaccinations. They give you, they have a lot of guidelines and a lot of things that are available as far as infection control is concerned. The Renal Physician Association has patient safety documents. The ESRD networks are another a place where we can get more resources from. Network 5, one of the ESRD networks, that a few years ago came up with a 5-diamond safety program, which it offers more helps in improving the QAI process and improving patient care. Coalition for Supportive Care of Kidney Patients, another place we can go. So the regulatory survey, the medical director is the leader of the QAI process, is accountable for all outcomes. The State Department of Health organization is responsible for carrying out the survey. So it's usually the state who comes and evaluates the dialysis units to make sure they're doing the right things. And one thing to point out is, readiness for surveys should be a permanent state. It should not be that, we're expecting a visit from the state, so we should be ready now, but it's something that at all times that dialysis units should be prepared for the surveys, and they should make sure everything is the best that it can be. All new facilities that just open up need to have an initial survey by the state before they open up. And that often involves having a test patient and then getting reevaluated again after that test patient. And the goal of the survey the goal is that each facility should be surveyed every 3 years. of course, because of logistics and the fact that there are not enough state surveyors, usually this 3 years is not always followed, and a lot of times it ends up being longer than that. And any facility can be surveyed because of a complaint or grievance from a patient, staff, or any other team members that may have had a complaint or a grievance that's been brought about to the networks or other places. The ESRD core survey is a survey that started in 2014. It is the expectation of a dialysis facility's QAI program to engage staff in order to monitor clinical outcomes and monitor facility operations. QAI process to improve quality and patient safety and conduct performance improvement actions. Areas that need audit, the most important one obviously being infection control. The water system is very important because if the water is not good, the patients are not going to do well. How the dialysis fluid is mixed and how it's tested, how it's sterilized are all very important points that need to be documented and maintained. Dialysis equipment operation and reuse, if performed, it's probably unlikely nowadays that many dialysis units are performing reuse, but if they are, then that's a different area that needs to be addressed. So the following items if the surveys come to dialysis unit, there's a list of items that need to be provided to the surveyors within 3 hours of surveyor's request. And these include a list of all the patients who are getting dialysis at that dialysis unit and what are they getting in-center dialysis or home dialysis. List of all the key personnel, including dietitians, social workers, nurses, PCTs, medical director. In-center hemodialysis patient schedules need to be provided to the surveyors. Any isolation patients need to be specifically mentioned. And list of all the new patients in dialysis in the last 90 days. And list of all patients that have been deemed as unstable in the last 90 days. List of all patients that have been who have been involuntarily discharged in the last year. And there's going to be I have a few slides on this, but involuntary discharge has become less and less common nowadays, and there probably most dialysis units are not going to have involuntary discharge patients over many years. And I think that's a positive development. List of all patients lost to follow-up in the last year. List of home dialysis patients scheduled to be seen during the time that the surveys are going to be in the dialysis unit, in case the surveyors would like to talk to them. Patients who are some of the home patients also, if the dialysis unit has home patients. Hospitalization logs with admitted diagnosis in the last 6 months. List of patients readmitted to the hospitals within 30 days of discharge in the last 6 months. Infection logs for the last 6 months. All the patients dialyzing with 0 to 1 QAPI is probably unlikely that any dialysis units are now using 0 QAPI, but there are dialysis units that, including some of mine, that are using 1 QAPI, and those patients, the list should be available. So these items here should be probably put in a folder which is readily available all the time. And so if the surveys come, they can do this, they can be given this right away, because these are things that are required within 3 hours of them coming to the dialysis unit. So for involuntary discharges to happen, there has to be a lot of criteria that have to be met. And these are some of the CMS conditions for coverage for the involuntary discharges. So that the dialysis unit has to inform the network of a possible IVD as early as possible. There has to be comprehensive reassessment, often KDQL, and the patient should be considered unstable and discussed every month on plan of care meeting. There should be plenty of documentation and medical record about what the problem is, what is the center doing to resolve the problem, and there should be documents document the impact on the patient, staff, and the facilities governing body record. How is it affecting the facility? How is it making treatment for other patients less optimal? And documenting all the steps that are taken to resolve the problem, documenting the patient's response, written physician's order signed by both the medical director and patient's nephrologist of the patient discharge, and sending all the documents to the networks, agreements, letter of notification, etc. Attempts to place the patient at another facilities. This often becomes difficult because a lot of times these patients get labeled as problem patients, and because there's so the dialysis network is a limited environment, and many staff know each other. It becomes that the problem patients are singled out easily, and it becomes sometimes difficult to place patient and another facility. And sending all the medical records requested by the networks to the networks, and notifying the state survey agency of the IVD within 10 days of discharge. The network's role in the involuntary discharge is to provide support for all aspects of dealing with problem patients and in general patient-provider conflicts, initiating formal procedures leading to involuntary discharge, requires notification of ESRD network 30 days prior to discharge. Of course, this is not necessary if there's if there's immediate threat looming that is cannot be dealt with readily. And the renal networks can do help with de-escalation techniques, self-awareness, staying calm, and some of these techniques. I'm not gonna read these all out, but just common sense techniques. People like to be asked rather than told to do something. People like to have their options open and given options. They wanted to have a second chance if they made a mistake. And things like tips like listening, saying things like not saying things like "I understand how you feel," because patients often don't see it that way. And meeting the patient where they are all important techniques, and these are some other helpful techniques that can be employed to help de-escalate the situation and calm things down. So to the best, so for the best of the patients and the unit. All right. And when the surveys come, then they require certain things to be available within 1 day of the surveyors being there. So these are the information that is required within 1 day. Vaccination information, what percentage have had which vaccinations, the staff schedule for the last 2 weeks, policy and procedure manual for patient care, water treatments, etc. These are the facility policy and procedures, patient suggestions, complaints, grievance log for the last 6 months, adverse events documentation for the past 6 months, QAI team meetings, meeting minutes for the past 6 months, life safety code attestation, and staff practice audits for infection prevention for the last 12 months. And there are some water and dialysis outcomes that the surveys will request within 1 day of being there. and daily water system monitoring for the past 2 months. Chlorine testing for the last 2 months, are they all done within the time period that is required? What happens if there has been a chlorine breakthrough? All of those things. Bacterial and endotoxin results for the last 6 months. Chemical analysis of product water in the last 12 months. Um, Staff practice audits for water testing, dialysis fluid mixing, microbiological sampling. All of those need to be provided in the last year. Then the surveys also need some equipment maintenance information for the after 1 day of being there. Documentation, preventive maintenance and repair of hemodialysis machines, calibration of equipment used for the hemodialysis medication, calibration of equipment used to test dialysis pH conductivity, the Phoenix meters, and similar equipment to that for the last 2 months. On day 2 of surveys being present, then they have a separate list that they need to have available to go over. Completed personnel file review worksheet, completed CMS end-stage renal disease application and survey and certification report. And the steps of the visit, when the surveys come in, first is introductions, who's who the surveys are going to interact with during their probable 1 week stay in the dialysis unit. Then they do a flash tour, they walk through the dialysis unit, they look just very briefly to see the infection control, how many patients are there, how is the dialysis unit situated, and then they will go into a conference room of the dialysis unit where the core survey worksheet is filled out, and then they conduct observation. The surveys sit in the dialysis unit, often in the nurse's desk, and they observe hemodialysis care and patient infection control. And then they are able to do patient interviews, staff interviews, medical director interviews, other interviews as they see fit. And finally, they review the QAI program. They go over all the documentation for the QAI meetings. And then there is an exit conference when everybody goes into the conference room again, and that surveys give their just a brief synopsis of what they have found while they have been in the dialysis unit in the week that they have been there. The results of the survey, and this is based on the CMS conditions of coverage. There could be 4 different possibilities. So it could be that the surveys find the dialysis unit to be in full compliance with no deficiency. They could have standard level deficiencies where corrective action plan letter needs to be submitted within 10 days. Conditional level deficiency, they are more serious, and it may result in the resurvey of the dialysis unit within 30 days. Immediate jeopardy is when the surveys find the dialysis unit to be unsafe for patient care, and the immediate action is required at this time. And if the deficiency is not quickly resolved with the immediate jeopardy, then the center will lose its Medicare-Medicaid provider agreement. And as such, they will not be paid by Medicare or Medicare any longer. And most likely the dialysis unit has to be closed. So follow up, a letter from the surveys detailing citations found during the survey. The letter will include directions regarding submission of action the facility should take to correct the deficiency, The dialysis unit is usually given 10 days to correct the deficiency and come up with a plan of action on how to correct them and respond to the surveyors. A repeat survey may be undertaken within 30 days. And if the deficiency is not corrected, the facility will be in jeopardy of losing a CMS certification. Immediate jeopardy, we already talked about that. And if the deficiencies are adequately addressed, then the facility will receive a letter stating so. So I'm sorry, this slide is very full, and there's a lot of information in it, but it's just basically a summary of everything that we talked about. There's nothing new on it. So I just put it as a summary slide. And I think that's my talk. We have about 5 minutes for any questions. I'm gonna stop sharing so I can see everybody, and let's see if there's any questions on the chat. And I don't see any, but if anybody has any questions, please you can come off mute and let me know, or put your questions on the chat.
Yes, recording will be available later and slides as well. And I've just put a link to the feedback survey in the chat, and you'll receive it in a follow-up email as well. So we welcome your feedback. We do have one question. Is transplant data required for QAPI reports?
Yes, so I think we do need to have how many patients are waitlisted, how many patients are referred. So those are information that need to be looked at during the QI process, and making sure that the center is following those data.
Great, thank you for that. Give it just another minute for questions. Well, you did such a great job. Then you've answered everybody's questions, I guess. I'm gonna share.
Thanks everyone for joining. I appreciate it.
I'm going to share my screen really quickly. As I mentioned, there is a link in the chat for the survey. You may not know this, but the forum is a volunteer-led nonprofit organization with limited financial resources. So if you enjoyed this webinar and would like to see more content from the forum, please consider making a contribution to our organization. Lastly, if you're not following us on social media, please do. You can help us spread the word about all the forum has to offer. And thank you again so much for joining us today. We hope you have a great day.